Everyone. Dr. Chen, thank you so much for joining us. We are just really grateful that we're going to be able to listen and learn and dialogue with you today. I'm Mark Levine, City Council member from Northern Manhattan, chair of the City Council's Health Committee. Welcome everyone to another one of our continuing series of discussions about the challenges facing New York City in this pandemic as we come out of this pandemic and what we can all do to get beyond this. We like to do a little bit of bilingual here, so brevemente, yo soy Mark Levine, concejal y presidente del Comité de Salud del Consejo Municipal. Bienvenidos a esta otra en esta serie de charlas acerca de los retos de esta pandemia y lo que podemos hacer en Nueva York para enfrentar a esta crisis y superarlo. Siéntese libre de hacer sus preguntas en cualquier idioma. As always, this is going to be a conversation, and so we invite you to use the chat function here in Zoom to give us any questions. If you're following on Facebook, you can post there too, and we have folks who will be monitoring that. I'm really excited about our topic today, and so excited about our guest. We're going to be focusing on what I think is probably the biggest and underappreciated storyline of this pandemic so far, which is the incredibly large number of people here in the city and nationally who face often debilitating long-term symptoms as a result of being infected with COVID. This is a story which has not been told enough publicly and has often left patients themselves to fend for themselves out there against a society and sometimes even a medical system which has not taken them seriously. That is starting to change, thanks in part to activism by Dr. Chen and others. But I think still far too often, patients are trotted out as examples of why we should be worried about contracting COVID, and that there's not enough emphasis on research to treat long COVID, to disseminate information on treatments which are already available, and to help connect people to the care they need. And I really do want that to be a focus of this discussion. I think there is cause for hope for people who are struggling with long COVID. Science can deal with this. Science will deal with this. We just need a society that's willing to devote the resources and attention and respect to people who are in the grips of this disease. Others have said dramatically and appropriately that this may come to be seen as the largest mass debilitating event in history, or one of them. And there are estimates that as much as 30% of people who get the virus will have long COVID. And just in New York City, that could ultimately mean at a minimum hundreds of thousands and potentially 1 million just in the city, depending on how many people ultimately are infected. So this is going to be arguably the last big fight of this pandemic for us to help care for and support and treat those who are struggling with the long-term implications of COVID. So thank you for joining in this conversation. Dr. Chen, thank you so much for joining us. Thank you for what you've done to help to bring treatment to people who are struggling with long COVID. I'm going to ask you to say a few words about your history and how you got involved in treating this disease, but you are now the medical director, or the director overall, of the Mount Sinai COVID Center. Is that correct?
That's correct. So my official title is medical director for the Center for Post-COVID Care. I do hold several other titles for the Department of Medicine at the Mount Sinai downtown. So to give a little history of,
could you just tell us first about how you got involved in this? Because your background's in endocrinology and I think diabetes. And how did this become your, if I could use the word, your obsession over the past year?
I wish I didn't have to use the word obsession, but it is now an obsession. And so we always look back to the pandemic and we think about what we did in the past year and how we got to where we are now. To tell my story, it's actually very interesting. We actually opened a new medicine practice at Union Square the week of COVID-19 when we were told to close all our practices. So we opened for a week, and then we were told summarily that we had to, stop seeing patients in person because everybody was under quarantine. And that was, I believe, the first week of March. So it
Incredible.
was, yeah, incredible. We had a 2 year journey in designing a new medical space that was beautiful. It just finished renovations, and then we walked in and they said, close your doors. But we didn't all go home, as you know. We were sent to other parts of the health system as well as other parts of the local health system downtown to take care of very, very sick patients. This includes in the medical wards, taking care of the patients who were brought in with very severe disease, to take care of them on the floors as well as in the ICUs, to manage their ventilators, to treat their infections. And then for me personally, actually being diverted, number one, to build and prop up one of the testing sites for COVID-19. And we had to get that in short order. We put that in place, I think 48 hours after the closing of our practices, and we were able to test many of the patients who were having symptoms but otherwise couldn't get testing at other parts of the city. In addition to that, we had a tent downstairs, downtown, next to the hospital on Nathan Perlman Place. I was in charge actually of running that tent, doing offloading for our emergency rooms. There were quite a few sick people in the ERs, and they were overwhelmed, and we had to staff the tent in order to make sure that the ERs has space to send the patients who are less sick. And then from there, actually, just really feeling the health system's response and the need of these patients who are being discharged from the hospital and from the ICUs, because these patients are still sick. They're not completely recovered by the time they leave. And the idea from our health system leadership was to say, well, there's got to be something that we have to do for these patients after they leave, make sure they go back to normal. And having said that, we decided that we needed a center to look specifically at this question of patients who are post-COVID, seeing what type of illness if they had, and what we need to do for them for their recovery. So that's how we
Well, we
got
are so
started.
glad that you had this has become your passion and your obsession, as you said. Could you just give us a big picture answer to the question of what is long COVID?
I mean,
What is this disease?
I mean, we
Is it a
we
vascular
categorize it.
disease? Why do people get it?
Yeah, I mean, we actually don't know, and I actually take no insult to my ego by saying I don't know. And the reason is because COVID-19 coronavirus itself is somewhat new. I mean, there are other viruses that are similar to it, but the impact that it's made and the severity of diseases in so many patients, this is still very new to, I think, the medical community, despite having studied it over the past, I would say, 14 to 16 months, right? And one of the things we start noticing, in these patients is that they have a longer syndrome of just illness after their initial illness. And this doesn't actually correlate um, concretely with the severity of symptoms they have when they first get COVID.
So
There are
this is
patients.
such a key point that I don't think is appreciated.
Mhm.
So it's not that people who have a very intense early stage of COVID-19, maybe hospitalized or have a very difficult couple of weeks at home, are more likely to get long-term symptoms. You could have someone who has a fairly mild early stage of the disease, who then over time progresses into more debilitating symptoms. Is that accurate?
That is completely accurate. And I think, as you said, it's something that's very, poorly, I guess, number one, understood, but then also poorly appreciated. Because, many people during the height of the pandemic, their belief was, I'm young, I'm healthy, even if I get it, I get a mild disease and that's it, I go back to normal. But that's not the case for many of the patients we're seeing. I mean, we have patients who are young and healthy, who are healthier than the average. You're looking at patients who, run marathons, or, they're triathletes, or, even just healthy individuals who exercise on a day-to-day basis and, don't have any medical illness. But after their mild course of COVID-19, they've had prolonged symptoms, sometimes in many of them for months, some of them even since the beginning of the pandemic in April or in March. And these symptoms that they have are very unrelenting.
Yes, and it's been demoralizing, in particular because I know many patients have felt like society didn't acknowledge what they were experiencing was in fact long COVID. I think earlier in the pandemic, even some doctors didn't. Fortunately, that appears to be getting better. The list of symptoms that people with long COVID experience range from fairly mild to downright debilitating. And they include physical symptoms, but also it's increasingly understood to include kind of cognitive symptoms related to brain functioning. Could you summarize what is the list of symptoms that are most common with this disease?
Yeah, I mean, it's a primary respiratory illness. So, of course, many of the patients will have shortness of breath. They range from shortness of breath with mild exertion. Let's say you're walking up a hill, going up a flight of stairs. I mean, for the most part, most of us, without COVID before the pandemic, are able to do that without any problems. There are patients who, with that type of exertion, now are short of breath or have difficulty breathing. But it's more severe than that. There are some patients who will report to us, that when they're sitting, when they're at their computers, that they feel short of breath. And that is actually very surprising, because you're looking, again, not at patients who were on the ventilator for 30 days and ill in the ICU. These are patients who literally were told, hey, you're not doing that bad. I mean, you had your illness, and then go home and quarantine, and you should get better after 2 weeks. But the problem is they didn't get better. So that's the type and the severity of the illness we're looking at. Beyond the pulmonary aspect, there is the cardiac aspect. There are patients, many of them having tachycardia, meaning rapid heartbeat, having slow heartbeat, and these are things that are very random in occurrence. So what's happening is they would go about their day and have sudden episodes where it feels like they're out of control of their bodies because their heart is beating so erratically. There are patients who are professionals like you, like me, running companies, doing work on computers or otherwise, not being able to get through the workday because they feel that they just don't have the mental capacity to do it. And then there are patients who are so fatigued that even if they can work, they aren't able to stay up and have the energy to go through the whole day of work. And the thing is, if you take these individual symptoms and say, well, we can try and treat this, there are some medications, we can do rehab, and we can help the patients get through it. I mean, even then, that may not be a big hurdle. But now you're looking at also these patients, many of them having multiple symptoms, meaning you're having the tachycardia along with the shortness of breath, and you can't get through your day of work because you're too tired. And just imagine that happening to someone in their 20s or their 30s when they were previously healthy.
Horrible, horrible. And what about brain function, which it seems to be increasingly understood to be not that uncommon as one of the more debilitating symptoms of long COVID?
Yeah, I mean, it's really unfortunate. The inability to kind of think, and sometimes even you know think of words that you would usually know, right? It's not about saying I'm a highly functional person, and then now I get tired when I work. It's to the point where you have college students who says, I can't get through my textbook reading it because I can't do my work because I'm just not, it's not processing. And having that day to day, is very, very debilitating, to the point where, we have students who drop out from school because they can't and they aren't able to continue.
Yeah, just uh, brain fog has been a term that's been used by so many. I just want to read something that Noah King posted in the chat. It's not really a question, but it's a point that we just can't emphasize enough. She says, "My daughter-in-law has this and cannot even get out of bed. The doctors told her it's all in her head until she found a good doctor, but she is not getting better." Uh, so, Dr. Chen, I imagine you hear testimonies like that quite often. Is that correct?
That's
So,
unfortunately correct.
how can it be that with 12 months into this crisis, there's still medical professionals who are downplaying this? Is that still the case today? And my
I mean,
goodness, how can that
I,
be?
I mean, I wouldn't say it's downplaying. I think, and I'm not trying to cry because I'm a medical professional. I'm trying to protect my colleagues, but it's been a hard year on us. It's been a hard year, and when we're still trying to catch up again with our regular patients because they haven't seen doctors in so long and they're sick. So for many of us, we're overwhelmed with how much we have to do. And having said that, much of what we do is reliance on, number one, the story from the patient, but it's also reliant on the testing that we order for the patient. And I think it's not because we're trying our best to kind of brush off these symptoms. It's because when we look at patients, we look at empiric evidence from the testing to kind of back up the patient's claim. And the unfortunate part about long COVID is many of the symptoms, when we do the testing, when we do the due diligence to look and see what's causing these symptoms, we're not seeing it. Many of the patients, when they come to our center, they would have seen multiple pulmonologists or multiple neurologists and had, you name it, all the testing done, like the literal $1 million workup, where you're doing MRIs, we're doing CAT scans of the chest, you're doing Holter monitors to check heart rate. And we see some of the things that may cause the symptoms, but it's not drastic to the point to say that, this looks like this positive test is the thing that's debilitating you. And we're not seeing that. Like, many of the tests are coming back either normal or just borderline normal. So we're not seeing that evidence physically.
And of course, you don't test positive for the presence of the virus in your body at that point, in
No,
most cases, right?
in most cases, no.
So I mean, this complicates, I think, the patient experience. It's a complication for doctors, but I think it complicates the patient experience because, we're used to diseases where you go in and you get a blood test, or you take a urine sample, or some other exam, and they determine that you have a certain condition, which I think we've all had the experience of feeling relief because I now know and it's been confirmed and we can deal with it. But it's so frustrating for patients because they know enough to know something's wrong, but they go to a doctor and they say, we're not seeing anything. So, I mean, how do we navigate that? How do you advise a patient to navigate such a situation?
Well, I mean, we're still, I think, learning at the center how to navigate that, meaning as physicians. Because I think one of the first things we decided that we have to do is trust in the patients. And I think that comes from actually seeing many of our colleagues, how they were affected with COVID-19. I mean, like, they are hardworking people who, you know, jump to the front of the lines to take care of very sick people, knowing the
Yes.
dangers. But
Yes.
for them to be exposed and to have, coronavirus and then get through it and still have symptoms and tell me that, I'm still sick. I don't know why I'm still sick. That's something that says, this isn't something that's fictitious. This is real. And number two, the sheer number of people reporting this, I mean, that's also, I think, very real. So I think the first step for us was to believe that the patients, that they had this. And then to do the diligence to, number one, look for anything physical that we can treat. I mean, take for instance someone who was in the ICU, someone who, was in the hospital. I mean, we could see some long-lasting damage on imaging and testing that we can direct treatment to. So that's the goal of the center, to look for those causes. And then for the patients who don't have those causes, then I think the next step is to actually look for things that may help improve the patient's symptoms, you know, either like sequentially, so that at least we're trying to get them better, even though the cause is still, elusive. And that's what, when what you mentioned comes into play, the science. Because along with treating and diagnosing patients, we also have a science unit who's studying this, who's looking into, what's the common thread with all of these patients. Can we figure out if there's anything that links all of these symptoms, or even some of the symptoms, to something, so that we can then direct the treatment. And then in parallel, also studying our treatment strategies to see what works and what doesn't, and then putting our energies into the ones that work and developing them further.
And I do want to ask you about the research in a minute, but we have several questions and comments on the question of just who's getting long COVID. And I'll just read a comment from Clem Tracy. Sure. I'm a long hauler at Mount Sinai. All of the fly tests have come back normal. It's not only difficult because you can't understand the symptoms, but it also makes it impossible to understand how to determine if you are getting better or worse from the suggested treatment. I don't know if you had a comment on that, Dr. Chen. It wasn't really a question, but a frustration.
No, I mean, the frustration is very real. I mean, again, this is I hate saying it because it makes me feel vulnerable, but this is a new illness. This is something that we don't know. Like a year ago, we didn't know anything about this. And I think we know a little more now, but not everything. And having said that, the frustration is there because, for us, not just for the patients, but for us, because we want to know and be able to treat people and get them better. And I think we were all under the assumption that we knew everything we had to practice medicine. But now, when confronted with something that's completely unknown, we are unfortunately frustrated with this. And I think because of that, the patients will also be frustrated because we're not giving them the answers. Now, having said that, I think time is going to help. Unfortunately, it's not a good, it's not a comfort for many patients, but time will help because, day by day, what we're doing is we're learning, and learning from, again, the way we're treating patients. We're using tools now, developing them in-house to look at and follow patients and their symptoms. And I think over time, what this does is it gives us a better sense of what's happening.
So they have a couple comments on the age and demographics of who's being impacted. And Adam Green points out that he's 57 and very fit and eats well and was a college athlete, et cetera, and still now can't complete a 30-minute workout because of the fatigue. And he's someone who had originally had COVID back a year ago and now has just gotten diagnosed. So very frustrating. We had been speaking about young people, but the truth, Dr. Chen, is people of any age. I presume there's people in their 70s and 80s who have been hit by this as well, correct?
Yeah. I mean, can I be slightly grim?
Okay, sure.
Slightly. I won't be graphic.
Okay.
I mean, if we look at, coronavirus, the acute part of the infection, I mean, many patients who were older, they tend to have other medical illnesses. So, for the most part, not all of them, but many of them succumb to the illness. So,
Right.
and we are, I think, more vigilant of these older patients even after they recover. So we look after them more and we treat them, we take care of them more. So that, I think they're in good hands in regards to at least being followed and managed by a doctor. The problem is with the, sorry.
No, please.
No, so the reason there's such a focus on, I think, the younger population is that their response is atypical and unexpected of an illness. So we didn't expect that patients who are younger who get coronavirus to have all of these long-lasting symptoms as if they were what would be expected in an older person. So that's why there's more focus. But
Right.
You are correct. This long, these long, post-COVID symptoms, they do affect people of all age groups.
And we had a question from Melissa Schiffman was on the other end. Are there kids, people under 16 who have long COVID?
So I'm going to try and escape this by saying I'm not a pediatrician.
Okay.
But I do know that there are kids who have been affected by long COVID under the age of 16. And the reason I know this is because we do get patients who call in, concerned parents who call in, and we are working with the pediatrics department to actually see those patients.
And Bianca Dong asks about demographics and the question of whether, I think she's wondering whether does the incredible inequality demographically and who's impacted by COVID more broadly, which we know has disproportionately impacted Black and brown communities in the city and nationally. And she's saying, I'm curious about how long COVID affects Black, Indigenous, and people of color communities.
Yeah.
Is it a similar inequality?
I mean, I think, just looking at basic volume itself and looking at ratio of patients being affected, I mean, what we're seeing is that, if your number is correct and it's a 30%, or if it's the number that I usually use, which is 10% because it's easier to calculate, I mean, I would presume that, that many people of, color are also affected equally as, compared to Caucasians and, Caucasian Americans. But the thing is, I think it's hard to tell from our data alone. And the reason it's hard to tell from our data alone is you have to look at the capacity of our health system, our center, to see patients. And I think the total number dwarfs, the numbers that we've seen. And because of that, it's hard to say, on a population standpoint, a population health standpoint, how many people are truly affected and what, race breakdown there were. Now, having said that, that's where more work needs to be done to understand this. I mean, we can do it on a patient level, whether it be tens, hundreds, or thousands of patients. But I think the government and city officials have to look at this problem, and public health officials have to look at this problem with a wider scope, to look at, our entire population, let's say within the city, to say who was affected by COVID-19. We know that, we have testing data. But then after that, how many patients are actually having long symptoms? And that's something, once we know, we will know, the overall impact.
We have a question from PC Wong. My daughter has chronic fatigue syndrome / ME, which I presume refers to myalgic encephalitis, if I'm saying this right. Also started by a virus that has similar symptoms. Has anybody linked the two? Has anyone linked ME or chronic fatigue syndrome with long COVID?
Yeah. So I think there are groups that are trying to find that link, because, as you know, there are diseases associated with viral illnesses and, long-lasting symptoms, and CFS, ME/CFS is one of them. Unfortunately, ME/CFS is very, very hard to diagnose. Sometimes there are causes, sometimes there are not. And then, beyond that, there's multiple causes of ME/CFS. So we can't say directly right now that, coronavirus can lead to ME/CFS, but, some of the symptoms do overlap. I think it's just too early to tell whether or not this is one and the same.
I just want to read something that it's not really a question, but Dalene Naiji, forgive me if I'm mispronouncing the name. She says, diagnosed a year ago, age 48, spent 2 months with complete, and you're going to know what these terms are, doctor, complete anosmia and brain fog, have had phantosmia and parosmia ever since. Maybe 70% recovered at this point. I feel, in quotes, lucky. It's less physical, but the psychological is debilitating sometimes. I imagine, Dr. Chen, that you recognize this type of challenge that Dalene is facing, correct?
Yeah, I mean, again, it speaks to the multiple symptoms that someone may have, and also the many type of things that you have to do in order to, treat these symptoms. And as you can imagine, for each of those symptoms, having, a different doctor trying to, evaluate and trying different treatments to get you into improve, you can imagine what this, this patient is going through.
I want to shift to focus a bit on solutions and perhaps cause for hope, because I do feel like science has seen diseases like this before, and we're not starting from zero, and that if we have adequate resources allocated to research, we're going to make progress here, and that there already are helpful treatments and measures people can take. So, I want to get into the hopeful upside, but first, there's so much buzz about the impact of COVID vaccination on long haulers.
Yeah.
I mean, tons of anecdotal reports of people feeling much better after the first shot even. Could you tell us what science thinks about this, and whether this might be an unexpected solution?
So unexpected to be sure. Um, Mostly because if you look at the mechanism for the vaccine, it's supposed to help prevent, infections. It's supposed to elicit an immune response towards the virus so that the body can fight the virus. So for it to help with long COVID symptoms is very surprising, mostly because we thinking that long COVID symptoms aren't directly due to the virus. Now, do we have any data that says, well, maybe this is happening, the virus is a repository within the body, and that the vaccine is causing an immune response against that, I guess full focus of virus that we're not detecting and eradicating it? I mean, it's possible. I don't know if that's the truth. Actually, don't quote me as saying this is the truth, because I don't know, but that may be one reason. The other so the other thing is, it is a lot of anecdotal evidence, or anecdotal response to the virus. So I think studies need to be done to actually look at this group of patients and say, does the vaccine really help? And I was a part of another group of thinkers around the world, both within the United States and also outside, who were looking at different aspects of long COVID, and we had discussed this. And I think there is actually interest in running studies to say whether or not this group of patients actually benefits from the vaccine. And
Would
if
you
those, oh, sorry, go ahead.
please?
No, and I think it's important also because, if you look at the sheer number of patients who may have long COVID syndrome, some of these patients may not want the vaccine because I don't know if it may make them worse. And that is a concern that many
So you wouldn't
patients.
go so far as to recommending to a patient that they get vaccinated in hopes of improvements? You don't feel that the research is strong enough on that yet?
I think so. Let me be specific and say, I think you should not get the vaccine if under the impression that it will make you get better from your long COVID symptoms. However, you should definitely get the vaccine because it prevents, number one, reinfection, which we don't know and aren't sure that can happen. There are reports. And number two, also for protection against the variants, which again, because they're so new, we don't know if those can reinfect you.
And also to protect the people around you, because you don't want to get an asymptomatic case and pass the virus to someone
Absolutely.
that you have
Absolutely.
contact with. We got lots of questions on whether there is recommendations on foods to eat for people dealing with long COVID, or foods to avoid, or dietary supplements, or anything like that you recommend.
I mean, being a man of science, what I do is go by evidence. Unfortunately, there really is lacking any evidence right now telling us, from that perspective, what you should not eat. We actually do have doctors and nutritionists who work with the center that have seen some of our patients. They do report some mixed findings where some different diets, depending on patient, can actually help with oxidative damage, and that can actually help with how they feel. So there's been some positive response, but it isn't general.
Are there adequate resources being devoted to this question of whether dietary changes, to study whether dietary changes
Yeah,
could
there
improve?
are. I mean, we do look at different aspects of treatment. Dietary is one of them. Unfortunately, resources are limited, so we can study several things at a time. But and whenever we study more things, the resources do get stretched. So it takes a certain amount of interest, meaning from whoever the people running these studies, to actually look at the data, and we do look at it, but then it also takes a resource to analyze and enroll enough patients, run the studies. So
There
we're
are
trying.
there are also physical therapists who have some who have developed a similar obsession to you, Dr. Chen, and are really focusing their entire practice on helping patients with long COVID. Um, do you have any insight in whether and under what conditions physical therapy can be helpful to long COVID patients?
Yeah, I think physical therapy is actually really good for long COVID patients, because much of the symptoms that, they report, the brain fog, the shortness of breath, the exercise intolerance, the fatigue, I mean, the physical therapists are able to assist with and evaluate, those symptoms. In fact, one of the stronger partners that we have with the center is actually our physical therapy department, to the point that they're now completely overwhelmed, is that they're developing programs to help patients, slowly build their strength, and then also slowly to deal with the symptoms that they have. At this point, Mount Sinai, physical therapy department has devoted so much of their resources to this problem that I think almost everybody in the health system in that department is seeing long COVID patients. In fact, we have also started um, started using a trusted network of physical therapy groups around the city, private groups, to also assist with these endeavors.
So these are independent family doctors or specialists who have their own offices around the city who are developing expertise and starting to specialize in long COVID. Is that right?
Well, no, so they the rehab department developed a program that they use for long COVID patients that's been shown to really been helpful for many of
And
the
they're sharing
patients,
it with
and they're
PT
teaching it
practices.
exactly.
Okay, understood. Understood. So we have a really good question from Don Gresham, which is, uh, can you provide examples of long COVID symptoms for which one should seek medical attention, and or at what point should medical attention be sought after experiencing long-term symptoms? Uh, and I guess, the question of even what kind of doctor should one go to uh, if you think you might have long COVID?
Yeah. So not an easy question to answer. So first things, in regards to how long. I mean, when we enroll our patients, we see patients if they have symptoms, more than 60 days after their initial exposure. Okay. So that's an easy
Okay,
part
that's
of the
an
question
important
to
marker.
answer. But that's a
Yep.
good marker because we expect the initial disease to be really be gone and completely resolved by 2 weeks. Now you may have some residual illness or weakness, and that may take a little time to get better. But if you're having symptoms, a month out, we would think that maybe these symptoms can last longer than that. So that I would recommend be a good time period to at least start seeking help. Now, severity of symptoms, that is harder to say, right? Because the severity for our patients has been different depending on, number one, the type of symptom, also number two, how old the patients are, and number three, how much it affects their day-to-day life. I spoke to someone yesterday who told me, well, I have these symptoms, but they're not that bad, except for this, blood pressure that I can't, seem to get down. And say, well, that's important because you have to control your blood pressure because it can lead to other things. So please come see us. and we'll take care of this. There are other patients who say, well, I'm just a little short of breath, but I really want to find out why this is happening because I want to get back to doing what I used to do. So we want to see you as well, because what happens is that can, give us a little bit of knowledge, like what's so different about you where your symptoms are mild, whereas this person who is similar to you when we first look at you, with their symptoms are so severe. So again, it's about, I guess, the patient's perception of how much distress these symptoms are causing them, and then that would be the other marker for you getting the care if you can't or you aren't able to handle those symptoms. And then the third thing, the type of doctor to see. I wish I can say everybody come to me and that'll be great. I can't say that, unfortunately. But I would start at your primary doctor, because I'm a believer that your primary doctor is someone that should be coordinating your care, someone that should be,
Yes.
helping direct and tell you where to go next. Because if everyone went to their specialist, then the specialist will be overwhelmed, and you may get a lot of different testing from a lot of different sources without someone pulling everything together. So I would say trust in your primary doctor and let them help, you know, bring you to the right person next, so they can take a first look and then from there guide you to where you need to go.
I want to pause and acknowledge that there's some very helpful links in the chat from Survivor Corps, which is really a grassroots movement of people who've had COVID, and it's now really focused on long COVID. And Andrew Lindsay put a link in there, a couple links in the chat, including one that listed a 100 symptom checklist. My goodness. So Dr. Chen, you're an endocrinologist by, is that your pre-COVID training?
Correct.
Okay. And is that emerging as the specialty that is most reorienting to deal with long COVID, or are there a variety of other specialties?
Absolutely not.
Okay, got it.
It's by circumstance, and I love all of my endocrinology patients if they're watching, but not quite. I really, again, the what I said about the primary care, I think that's where we need to go. And the reason it we need to look to our primary care doctors, because they are really the jack of all trades. And being that, I really hope that they are the ones who can guide patients as they should do in any illness. I mean, when we at Mount Sinai started not the Center for Post-COVID Care, but actually the World Trade Center program. I mean, that was the model that they used, is that they have a intake practice of primary care practitioners trying to guide the care of a special group of patients affected by the 9/11 disaster. And what it did was it helps the patients be engaged with, number one, all of the providers, but then also have a home base for them to go to whenever they have questions. So I think primary care really needs to take this mantle of being able to help patients navigate their care.
Yes. So now there are growing resources in the city that I think are going to be incredibly important long term. Our public hospital system, known as Health and Hospitals H&H, has now designated 3 COVID centers of excellence. And I'm blanking which hospitals they're at, but we'll try and produce that and post it for you. I'm sure you're aware of this. Could you talk about the extent to which other hospital systems, other medical institutions are starting to create something that really could endure as a long-term resource, whether it's a center or an institute, et cetera, focused on this?
Yeah, absolutely.
Mount Sinai, of course, has led the way, correct?
Trying our best. But yeah, I mean, we started. I do want to say that I think we were the first. But since we started, we've engaged with many health systems, not just within the city, but also around the country, and even outside of the country. And the goal is not to, be competitive, but we're trying to be collaborative. I think if we form a coalition of these centers around the country, and we engage with the government and we engage with the scientific community, I mean, that's the only way that we can quickly learn and be able to treat patients and gather enough data and evidence so that we can learn from each other. Because again, having a new disease doesn't mean everything is in pause and the patients can wait. Having a new disease that we don't have to do, that we don't know how to treat, that makes it even more important for us to work together.
Right.
So yes, there are centers around the country being started. I know in California, in Oregon, in Seattle, on the west side, in western part of the country, in
Any others in New York City
Great
that
Lakes
other
area,
than health and
Texas.
hospitals?
Yeah, Montefiore, I believe, has a center. I believe Presbyterian has a center as well. So definitely, there are centers there. And then our neighbors in New Jersey, of course, they have centers.
That's great. We had one or two questions earlier, and I apologize, I can't remember the name of the person who asked, but maybe they'll chime in again, about people who have jobs and are struggling to explain long COVID to an employer because it's a somewhat unknown condition in some cases. And that raises the question on the extent to which things like long-term disability are available. Could you comment on the extent to which our society is starting to pivot to support people in the workplace with these challenges?
To be completely honest, in the beginning, it was tough. I mean, us doctors, we do work on things like disability. We do work on, things like FMLA to help the patients and the employees understand, the medical care that the patient, needs to undergo in order to try and recover. And it's a difficult thing to do when you don't even have a diagnosis code in the IDC-10 to ICD-10 to categorize the disease. And that's what we were facing in the beginning of, when we started seeing these patients, is that we weren't able to say that this is what the patient has because we can't categorize it. Now it's gotten better because there are now some codes that we can use to, number one, describe the illness. But then despite that, it's still very hard to prove because we go back again once again have to go back to what the patients are testing positive for, which is scant very little. And that's when we know that other things need to be done in order to start evaluating these patients. We need different scales to look at their fatigue level, their cognition, because that type of testing is also evidence that we can use to prove the patient's illness beyond just a simple CAT scans and MRIs and blood tests.
So many of us who got COVID, it was in a time where you couldn't get a test in New York. I got it in late March. There was no way I was getting a test. And I see that Casey or Cassie Keith is commenting that also of having had it early on and not getting a test, but now having months of symptoms. Does that complicate a diagnosis? Does it complicate getting acknowledged by an employer or by a disability benefit?
Absolutely.
Right.
I mean, we in the health system, we try to see, again, all the patients. We have providers who are seeing patients who didn't test positive. We have people seeing patients who tested positive. And in the end, we still can't see everyone. And having said that, it's this way, I think, all around the city. And it's hard to say when we see someone who did not test positive, you know, like what was the thing that afflicted you? I mean, you may have had the symptoms of COVID-19 in the beginning, but we just don't know. There's no way to prove it. And now for you to have long-lasting symptoms based on an illness that we can't prove, it is so difficult to do. Now imagine us trying to explain that to your employer, saying, well, we think this is what the patient had, but we can't prove it. I mean, it's very difficult to, fill out paperwork and, have the recipient of the paperwork acknowledge that, okay, fine, this is what the patient has. It's an extremely large hurdle.
Naomi Bishop has clarified that the health and hospitals centers of excellence are located in Bushwick, Jackson Heights, and Tremont. And these new Gotham Health sites will provide comprehensive outpatient services for recovering COVID-19 patients. That sounds great. We need one in Manhattan, though. We're gonna have to work on that. But thank you, Naomi. And Charles Gans, who turns out had been the one who originally posed the question about workers' comp benefits, talks about a barrier that is the requirement that notes be submitted within 90 days of the date of service, and insurers enforcing that rule and using it as an excuse not to pay. I guess when you have a disease that develops over time and that you might not even get a diagnosis on 90 days out, that clearly is the kind of accommodation that we need to make. I think that there's going to be a lot that government needs to do to support the community of COVID survivors who are still struggling, including adjusting bureaucratic barriers in workers' comp, including clarifying rules of employers, and including expanding the kinds of outpatient treatment centers that are starting to emerge now in some neighborhoods. I really do think there's going to be a big role for the city government, probably at other levels, state and federal as well. Do you have thoughts on that, Dr. Chen? And as chair of the health committee, this is something that I need to work on. So what can we as a city do to support this community?
Well, I think number one, access to care. I mean, we know there are health disparities within all communities, whether it be big cities or, urban suburban areas. I mean, the access to care has to be better because there are patients out there right now who still can't get to a doctor. And that is in 2021, and it's just an absurdity.
Outrageous.
To be completely honest, that's an absurdity.
Yes.
And for them not to be able to get care appropriately, for any illness, not just post-COVID syndrome or COVID, it is completely horrendous. So that needs to be improved. And it's not an easy problem, obviously, but we need to be able to divert money to be able to treat everyone for their illness. And then beyond that, I think, the government and, the healthcare community needs to really learn about what's happening to these patients so that they can make the provisions for it. I mean, from a macroeconomic scale or just from a macroscopic scale, if you're looking at 10% of patients, for easy math, 10% of patients around the country being affected with long COVID syndrome. I mean, I don't actually have the updated numbers for the infection rates, but I would imagine that would add up to more than 100,000, 200,000 people. And that number is growing. And that's just a conservative estimate of 10%.
Yes.
That's injecting hundreds of thousands of patients into the health system that already
just in New York City. Yes.
Yeah, that already cannot give care to its existing patients before the pandemic.
Yes. I want to acknowledge a point that a questioner asked earlier, and forgive me, I've missed the name. Maybe they'll chime in again about the impact of this disease on family members and other people in the household and loved ones. Any disease that's serious enough affects the patient, but also the people around them. And I'm wondering if this is something that you and the profession are starting to think about, and whether there are supports for the circle of family and loved ones who have a COVID survivor amongst them, and what we could do more to support family.
I mean, psychiatry services and mental health services is another area that I think we lacked before the pandemic, right? I mean, and there's a certain amount of stigma that happens, for these patients themselves. They don't like talking about mental health because it's something that we don't like talking about within society. And I'm not trying to be political about it. It's just, I think that's the truth. And because there is the stigma, what ends up happening is you know, with with COVID and post-COVID syndrome, is getting worse. As you can imagine, anybody with any chronic illness is at risk for depression and anxiety. For someone to suddenly develop chronic illness when they were healthy previously is also a major stimulator for depression and anxiety. And we've seen this in the health system.
Yeah.
We have so many patients now that our mental health services are somewhat overwhelmed because we aren't able to provide for everyone.
So
So go ahead. I'm sorry.
no, thank you. We only have about 5 minutes left. This has been an extraordinary discussion already, Dr. Chen. I'm just so grateful. We're getting wonderful feedback from people who are interacting. So maybe we'll just try and squeeze in a few more quick questions if we can in the next few minutes. I'll try and get through as many as we can. So we have an anonymous question about whether there's any correlation between blood type and the severity of symptoms or effects of long COVID.
Not that we've seen.
Not that we've seen. But there was conjecture that a certain blood type might have made you more vulnerable to contracting COVID.
Correct.
What is our understanding of that question at this point?
I actually didn't even look at that data. I apologize.
Okay.
In regards to why it's more likely, I think there was I think I remember something, but I don't want to say it because I might be wrong. But I do remember that there was a blood type that was more susceptible to COVID-19, the initial infection.
Oh, we have a question from Grace Goodman. Is long-term COVID contagious to others in the household?
I would presume not, because you would need to have first gotten a COVID infection. So let's say if I had been affected by COVID-19 and I self-isolated and now I'm not contagious anymore, but I have symptoms, I don't think those symptoms are transmissible to your household without transmitting the virus itself.
Okay. So Dawn Gresham is asking whether there's any information on whether emerging variants of concern might make a patient more likely to end up with long COVID.
The answer is we don't know. But if we were to follow the illness, meaning if we said that COVID-19 can lead to long-term symptoms, then I presume that these variants can do the same thing, which is kind of scary because it tells us that we need to be even more vigilant right now in our social distancing and mask wearing until at least we're all immune or vaccinated.
Amen to that. Amen to that.
I have to throw that in there.
I'm glad you did. Look, we're worried because right now most cases in New York City are being caused by variants of concern, including B117 from the UK, B1526, which emerged in New York City, actually. The numbers have been bouncing around a fair amount of late, but it sure seems like a majority of cases are caused by variants. But at least you can tell us that we have no evidence that these variants will make people who get infected now more likely to contract long COVID. So
unknown. I wouldn't say no evidence. I would say unknown. Just to be careful, because I don't want a false sense of security among people thinking that this isn't going to be a problem.
Yes. And so Clem Tracy asks a somewhat involved but important question. Says the press often refers to dysautonomia, I guess, as a potential cause or correlation to long COVID, speculating that there might be untraceable remaining pools of COVID virus or virus particles in the body, autoimmune dysfunction. How would naming a potential cause affect treatment protocols? Can you comment on any of that, Doctor?
So I think those are three different things, actually, right? You're looking at residual virus pools versus dysautonomia versus, what was the third thing? I'm sorry, I want to scroll back up. Actually, I don't think I can scroll back up. But there were three different separate entities. And I think those are competing theories as to why, long COVID can happen within patients. And then, we did talk about, the remnant viral particles earlier in the discussion. Dysautonomia is just a loss of our body's ability to control the autonomic functions of our body. So the nervous system, what we do now, talking, moving, thinking, those are not parts of the autonomic nervous system, but, that beating of your heart or the regulation of your breathing, you don't actively think of it, but your autonomic nervous system controls all of that without your I was going to say consent, but it's not without your thinking of it. And that can be disrupted. And in cases when that's disrupted, it can cause many of those symptoms. And that's why it is a theory that this is one of the reasons why it happens. So again, competing theories that we're all looking into at our health system, as well as many other health systems. Hopefully we'll find the answer.
So we're just out of time, but very quickly, I missed a question earlier from Ernestine Bell Temple. I hope she's still on. She happens to be a prominent district leader here uptown, asking about whether there are focus groups, support groups for patients and parents. And we mentioned Survivor Corps earlier, but do you have any others that you are aware of, Doctor?
Yeah, I just wanna support Survivor Corps. I mean, they've been a very good partner.
Okay.
Because what happens is they are a very good repository of research, and also patient support. Because as I said, our health system, and I think every other health system, is not at this time able to take in all the patients. So having something like that as a resource is very useful, because it at least gives patients a place to go for, some good information.
Right. So unfortunately, we're out of time. This has been an incredible discussion. The feedback, I'm not sure if you're seeing the chat, the feedback, Dr. Chen, has been overwhelmingly positive. There's just so much gratitude for the work you're doing to treat New Yorkers with this disease, but also the fact that you took an hour out of your very busy day to talk to us about that work. I learned so much. I think a lot of people here watching did as well. And, I come away motivated to organize for a better response in this city to a disease which such a massive number, as the doctor said, hundreds of thousands of people, probably ultimately, such a massive number of people in the city are struggling with, that we need to organize to ensure active support for people struggling with this, active resources, medical resources, mental health resources, social and emotional support, survivor groups, adequate resources within our public hospitals and other hospital systems, and to keep agitating for more research. And I know a lot of that is taking place, but we need to be able to answer so many of the questions that we're still struggling with. And we have work to do to achieve that, but I believe we're going to get there. I believe that this city, this country, the world can get there, and patients are going to help lead the way as they've led this discussion today. So I guess we'll just turn it back to you, Dr. Chen, for any final words for us.
I mean, the final word is, I think, we're all in this together. And I think that's the most important thing. And, because we don't know enough about it, learning, I think, is the key for all of us to conquer this. And I think, in the end, just, I guess the final word is wear your mask and try and get vaccinated, so that at least you and your loved ones are protected.
Well, I couldn't agree more. So we post these videos. I think it'll be available on Facebook to rewatch, but we also post it on YouTube, and then I put the link on Twitter. So those of you who follow me on Twitter, if you like this or you missed part of it and you want to share or rewatch, this is a discussion that I think is really worth sharing and rewatching. So informative. Dr. Chen, you have a very authoritative and empathetic voice, which is a wonderful combination that we're really grateful for. Thanks to all of you for joining us. I'm sorry we're out of time. We'll be back for more on this very topic. I promise you, we will come back to the topic of long COVID. We know this is going to be a long-term fight, and we're going to be here with you to make sure you get answers and advocacy. Thanks everyone for joining us. Thank you again, Dr. Chen. And I hope everyone stays safe. Be well, everybody.
Thank you for having me.